This is Madhukar Trivedi. I am at UT Southwestern Medical Center, and I'm the founding director of the Center for Depression Research and Clinical Care. And I'm going to give you a brief vignette about our article that was published in the Journal of Clinical Psychiatry. What we were interested in doing was, as we all know, depression is very heterogeneous and people have looked at various components. Our focus in this article was looking at pain, irritability, and depression across many studies. Two large studies that were randomized control trials, one in depression called EMBARK, one in substance use disorder, stimulant use disorder called STRIDE, and a third one, which is a much larger real practice vital signs 6 project in primary care. Our interest was to figure out what is the relationship between pain, irritability, and depression. So for the purposes of this article, what we looked at was a nice brief measurement tool we have developed at UT Southwestern called P-FIBS, which is for intensity, frequency, and burden of symptoms related to pain. So pain is the P-FIBS. And we've also developed a brief irritability measure called CAST-IRR, looking at the measurement of irritability in the setting of depression. And so our focus was to see what is the relationship for pain versus irritability versus depression. And what we found across these three very disparate but large studies, that the rating instrument called P-FIBS has very good psychometric properties with good internal consistency, and it is positively correlated with irritability and depression. What was remarkable was that irritability really accounted for close to 50 to 60% of the effect of pain on depression. And just to take a minute, this really is significant because irritability accounted for a lot of effect of pain on depression. And the second thing is higher irritability and depression was associated with poor functioning, social functioning, quality of life, and productivity in work and non-work related activities. Additionally, what we found was that pain was associated with non-work related activity impairments, even after controlling for irritability and depression. This is again bears emphasis. Pain was associated with this impairment that was present even after controlling for the presence of irritability and depression. So as we as a field start dissecting the heterogeneity and looking at dimensionality of different presentations in depression vis-a-vis the RDoC criteria that the NIMH has been proposing, we really can actually look at these individual components that help us do two things in my mind. One is it emphasizes very well-designed brief measurement tools, so P-FIBS for pain and CAST-IRR for irritability, together with depression rating instruments like PHQ-9 or QIDS, would really encompass the entire picture, which would help us improve the outcomes, because often core symptoms are focused on, but these other things like pain, irritability are not focused on, and patients continue to report poor functioning, and our study did actually emphasize that. The final point, I think, is that the next step for us and for the field is to now look at biomarkers associated with these presentations of pain, irritability, and how they interdigitate with the neural circuitry. For example, in depression, some of this would be identified through brain-based markers, and some may even be identified with peripheral markers like immune markers, metabolic markers, as well as looking at gut microbiome.